Hello everyone, my name is Charlotte and I'll be your host for today. Welcome and thank you for taking part in MDPI's webinar entitled Advances in Echocardiography for the Assessment of Mitral Valve Disease. This is the first webinar in this JCDD series. I would like to remind everyone that this webinar is being recorded and the recording will be made available as soon as possible on the webinar's webpage. Today's session is also being live streamed on MDPI's YouTube channel, so hello to those of you watching us on there. Certificates of attendance are available upon request. To get yours, please send an email to jcdd.webinar@mdpi.com. Certificates will be delivered to those of you who are registered and are watching on Zoom, not on YouTube. Thank you for your understanding. There will be two presentations today of 25 minutes each. Each presentation will be followed by a Q&A session moderated by the chair. If you have any questions for our speakers, please post them in the Q&A box at the bottom of the screen. Please remember to mention the name of the person to whom you're addressing your question. Today's webinar is chaired by Dr. Nina Ajmone Marsan. Dr. Marsan is a cardiologist specialized in non-invasive cardiovascular imaging and currently working at the Leiden University Medical Center in the Netherlands, where she is a senior academic researcher. Her main research topic is the clinical applications of imaging in cardiovascular disease, with special focus on valvular heart disease, cardiomyopathies, and systemic disease. She is also the principal investigator of translational research projects in mitral and aortic valve disease. Thank you, Nina, for chairing today's webinar. I now hand you the microphone and wish everyone a pleasant webinar.
Thank you very much, Charlotte, and good morning to everybody. Welcome to this very interesting webinar, in my opinion. It was based on a special issue of the journal on mitral valve, which I was the guest editor together with Professor Norris. And it was really a pleasure because it included many articles of really great interest that I really suggest you to read. And two of the contributors are the speakers of today, and I'm very, very happy and honored to introduce them and share their presentation, which I'm sure will be of great interest. So the first one will be from Franco Faletra, that is the director of the cardiac imaging service of the Institute, Cardiocentre Ticino. I think he doesn't know, but I call him the Michelangelo of the 3D echocardiography because his images, his knowledge of the anatomy of the heart is really amazing, and it's really close to arts, I think. So it's really a pleasure to introduce him, we will have some questions for him at the end, and then we will switch to the second presentation. So please, Franco, go ahead. Thank you.
Thank you, Nina, for your kind of presentation. And I will talk about the multimodality imaging for mitral valve anatomy. Why we need to use multimodality imaging? Because with multimodality imaging, we discover live anatomy. Indeed, you can see here these two specimen, anatomical specimen of a mitral valve from above, from the left atrium and from the left ventricle. And we can have the same images, or most of the same images, with the 3D echocardiography, as you can see here, but differently from the anatomical specimen, we can have this in live anatomy. And this is really very amazing because you can understand something that is difficult to understand just looking at the anatomical specimen. We will start this lecture just showing this very nice, very old, but still a modern, very nice paper of anatomy written by pair of Robert Williams, in which they divide the mitral valve, they consider the mitral valve not simple flap of a tissue which open and close, but complex apparatus made up by several structures. And in particular, we will talk today about four structures: the annulus, the leaflets, the chordae tendineae, and the papillary muscle. Just started with the mitral annulus. This is a paper I wrote a couple of years ago about the mitral annulus seen from non-invasive imaging technique. And in this paper, we distinguish, this is the 3D echo, this paper we distinguish two, not two types of annulus: the posterior annulus, which is a kind of curved structure, and the anterior annulus, which is a straight structure. And this is the posterior annulus seen in the anatomical specimen. And you can see that the posterior annulus actually is formed by the convergence, juxtaposition of atrial wall, ventricular wall, hinge line of leaflets, and adipose tissue. All of this structure is supposed to be glued by a fibrous annulus, which is anyway incomplete. And this is really very important to understand. This is an incomplete fibro tissue which goes around this C-shape annulus. This is the two images of a histological specimen showing in one case is that short axis viewed cross-sectional, I mean, the annulus is a nodules of a fibro tissue that you can see here, but look at this. Here, there is no annulus at all. The leaflet is attached directly on the ventricular myocardium, or could be attached on the atrial myocardium, or could be attached in the junction between atrial and ventricular myocardium, but without a fibro tissue, without a cord-like fibro tissue. So this is the first important point that I want to stress to our people. We can see this kind of a convergence of a structure with the CT scan. For example, just have a look at this image here. We have the hinge line, we have a ventricular myocardium, the atrial myocardium. This part of darker area is the adipose tissue. In this case, we have also here the circumflex arteries. And probably the best way of looking at this complex posterior structure of the mitral annulus is the MRI, in which you can see really how the adipose tissue is penetrated deeply into this convergence of structure, and then you can see atrial myocardium or ventricular myocardium, hinge line, and this adipose tissue here. The reason why the adipose tissue is so intrusive in this structure here is because his role is of how do you say, insulating atrial myocardium from ventricular myocardium, so the electrical stimulus cannot pass through this structure, because or also because there is this adipose epicardial tissue here. Just go to the anterior annulus, which is completely different from the posterior annulus. So we can see the posterior annulus is a mix of four tissues with inconstantly glued by the fibro tissue, the cord-like fibro tissue, but the anterior annulus is completely different. If you look at these images from the book of Carpentier, you can see as the from atrial perspective, you can see as the myocardium of the left atrium goes and imperceptibly has been transformed by anterior leaflet. There is no structure here which divide the left atrium from the anterior leaflet. just the hinge line, just the fulcrum where the anterior leaflet move opening and close, but there is no anatomical nor histological structure here, which divide the left atrium from anterior leaflet. But if you look from the ventricular perspective, then you can see that here there is the hinge line of the aorta. Here, the hinge line of the mitral leaflet. In between, there is a space which is called the mitral aortical curtain. And this is another structure which is part of the mitral annulus, at least in its junction with the anterior leaflet. This is, you can see here that once again, this is the hinge line of the aortic leaflet, the hinge line of mitral leaflet. This space here is called the mitral aortical curtain. And this is the anatomical specimen who show the same thing: myocardium, left atrial wall, mitral hinge line, anterior mitral leaflet, and this is the aortic hinge line. And once again here, the mitral aortic curtain. The question is, can we see this with, for example, two-dimensional echocardiography? If we took attention, yes, a good images, you can see exactly the hinge line of the aortic leaflets, the aortic wall here, and you can distinguish the aortic wall from the atrial wall, which is a little bit more soft. And this is the hinge line of the mitral valve, and then this is the aortic hinge line, and then this is the mitral aortical curtain. But probably the best way of looking at this mitral aortical curtain is 3D echo. Indeed, with 3D echo, this is an image talked by the ventricular perspective. You can see the anterior mitral leaflet here, which open and close. You need a difference between dynamic and static anatomy. This is the hinge line is the fulcrum where the anterior leaflet open and close. And then here, there's a mitral aortic curtain. It's exactly here. And this is the anatomical specimen which show the same thing. This is another important thing that I would like to show you is the two of trigones, which are lateral part, peripheral part of the mitral aortical curtain. So two trigones here, which are really very important, as we will see later. Oh, this is a very famous paper of Bob Levine and also Marco Triulzi, which was a very close friend of mine. He passed away many years ago because of terrible disease. And Arthur Wayman. In this paper, they just changed the perception of mitral valve prolapse. Indeed, they just discovered that the l'annulus has a saddle surface, a saddle shape configuration. And this saddle shape configuration is present in all mammalians, from the mouse to the elephants. So they do have some kind of competitive advantages in the evolution of the mammalians. Indeed, Salgo just show what could be the advantages of having this kind of annulus instead of having flat annulus. He just discovered which the stress when you have this saddle shape configuration, the stress is just in these 2 points, which not okay. This is not a coincidence, are the 2 points where they are the fibrous trigones. So probably the fibrous trigones were support the maximum stress, the maximum tension of the valve, and then they become robust. You can consider it that the mainly the right fibrous trigones in the big mammalians are calcified. So this is a very strong structure which support the tension of all the mitral apparatus. So mitral annulus undergoes three types of motion: sphincteric motions, excursion and translation, and towards the apex, and the annular folding. We will see this is sphincteric motion that you can see very well with the 3D echo. And then you can see here the line of hinge line of a posterior mitral leaflet, and the line is pushed anteriorly, as you can see here. This is a diastole, this is systole, is pushed anteriorly. And for these reasons, the uh, the shape of the annulus is almost round in diastole. It become elliptic in systole because the bicommissural diameter remain almost the same, but the anteroposterior diameter is shortening very much, thus favoring the coaptation of leaflets. The other motion of the annulus, which is really very important, is the excursion toward the apex. And this is important because for many reasons, because when you put this excursion, the left atrial cavity becomes larger. So the pressure left atrial cavity is become negative. So this favor the flow from the pulmonary veins in the left atrial cavity. When you don't have this kind of shortening, because due to the shortening of left ventricle, this translation, when you don't have this kind of shortening, even though you preserve the radial shortening, you don't have you have this kind of left atrial cavity remain and does not enlarge, remain the same. The pressure left atrial cavity increase, and then the pressure in pulmonary veins increase. And this is one of the mechanisms of what we call diastolic dysfunction, with left ventricular function preserved, because the left ventricular function is preserved by the radial shortening, but not, there is no longitudinal shortening. This is the classical case of this disease, is the cardiomyopathy, hypertrophic cardiomyopathy, or other cardiomyopathy in which there is not this shortening of the annulus. And then we have the enfolding of the annulus. So the saddle shape configuration in systole become more accentuated for the reason that I told you before. Just go to the mitral leaflets. You know very well that the mitral leaflet, anterior mitral leaflet is longer, but the insertion of the annulus is shorter, while the posterior mitral leaflet is shorter, but the insertion of the annulus is much more extensive. And the posterior leaflet is divided in three scallop, P1, P2, P3, while the anterior leaflet is not divided into scallop. This division scallop is necessary because if there is no this incisure that divide the posterior leaflet in three parts, when the valve open, the P1 tether the P3. Instead, in this system, the P1, P2, and P3 are completely independently and can open freely. An important thing of leaflets is that the leaflets are two zones, which is called the rough zone, which is called the clear zone, both anterior and posterior leaflet. However, in the anterior leaflet, these two zones are very well distinguished because the leaflet is longer. A rough zone is the zone where the chorde tendine attach, while clear zone is the zone where there is no chorde tendine. And this is an anatomical specimen which show also the same. Rough zone is this zone here, clear zone is this zone here, which is of course more extensive in anterior leaflet because it's, as I told you before, it's longer. So this is the ventricular perspective of the leaflets, and then you can see here the rough zone, a clear zone here, clear zone here. But what is interesting is a lot of physiological implication is the fact that this rough zone, if you look at from a ventricular perspective, from atrial perspective, not from ventricular perspective, This raft zone corresponds to the coaptation zone. And this is important because, as you can see here, the coaptation zone reduce the stress on the chord tendine, because both stress are reduced by the coaptation of the leaflets. So if you have a kind of, I would say, curve configuration of anterior leaflet in this zone, it doesn't matter. Might be even better. But if you have a prolapse, so involving this coaptation zone, then this is a problem, because the chord tendine were subjected to abnormal stress, and then they can. So this is the problem of the prolapse. The problem of the prolapse is that the rough zone, the coaptation zone of the leaflet, which are not anymore coapted each other for all of this length, and then the chord tendina here will be stressed more than in a normal. And this is an image is made by a new system which change the light, the source of light, and then if you put the source of light behind the valve, then you can easily distinguish the rough zone, which is thicker because of the chord tendinous touch there, with the clear zone, which is more trans-illuminated. So just have a good a look at the chord tendine very quickly. We have three types of chord tendine: the first order, or the second order, and the third order. The first order are chord tendine, which also called the marginal chord, because are attached on the mitral, on the margin or near the margin of a leaflet. So when one of these chord tendine is ruptured, the leaflet flail. The second order chord tendine are very few, usually two, usually on the anterior leaflets. They are attached on the margin between rough zone and clear zone, and are very thick and more robust than the first order chord. The third order chord are very small one, are attached prevalently to the base of a posterior leaflet, or near the base of a posterior leaflet, and are coming not from papillary muscle, but directly from the muscular myocardium, from the ventricular myocardium. In echocardiography and CT scan, we can distinguish at least the first order from the second order. So the marginal chord from what we also call the strut chord. And you can see that this strut chord are more robust than the marginal chord. When you cut the strut chord, you don't have mitral regurgitation. So what is the function? What is the role of this strut chord? Actually, is not very well defined. What we know is that when you cut the strut chord, for example, during a cardiac surgeons for mitral valve replacement, the longitudinal shortening of the left ventricle deteriorates, worsen. So this strut chord is a kind of connection between mitral valve and left ventricle. And why they are so thick? Probably because they are in tension either in systole or in diastole. And there are other reasons, but so far we stop here, and then we will continue with if there is some questions over there. But remember, strut chord and marginal chord is the most important. And this is another scheme which showed the secondary chord, the marginal chord or primary chord here, and then you can see the differences in attachment, and this secondary chord, the strut chord, are more robust, as I told you before. Finally, the papillary muscle. So we have two groups of papillary muscle in mitral valve, one anterolateral papillary muscle, one posteromedial papillary muscle. What is the function, the role of the papillary muscle? Well, the papillary muscle shortening more than become thicker. Shortening and the length, because the length of the chordae tendineae are the same during the cardiac cycles. So when the left ventricle shortening, the chordae tendineae become relatively longer, and they will produce the mitral valve prolapse. But because of the papillary muscle shortening and same extent, so the chordae tendineae remain, and the leaflet remain in place. And this is MRI which show the shortening of the papillary muscle here. This is another interesting paper from Leon Axel, which is a radiologist at the New York Medical School. I met him many years ago. And what they found, remember, radiologist and non-cardiologist, what they found was that the papillary muscle does not attach as a single pillar on the atrial wall, on the ventricular wall, but as a lot of roots, as a tree, a lot of roots here. And could be important because the stress of a papillary muscle is distributed all of this base instead of being just in a piece of papilla. And this is distributed, also the vascularization and innervation of this papillary muscle go through these roots instead of going just one single papilla. And finally, the vascularization, just one slide to show you how the anterior papillary, anterolateral papillary muscle are at least two vascularization, one coming from left the anterior descending artery or by one diagonal, and the other one coming from circumflex artery, while the posterior medial papillary muscle usually have just one revascularization. Of course, there are some variability, and then I don't want to discuss this, but this is the main scheme of vascularization of papillary muscle here. So this is the reason why this is more subject to the ischemic, and this is the reason why usually the rupture of papillary muscle occur in this area here. So take home message. The mitral valve is complex apparatus, which include the annulus, the leaflet, the chordae tendineae, and the papillary muscle. Each of them has a specific morphology and function. The coordinate and synchronized work of this component allows an easily improve and in diastole and prevents the backflow in systole. Thank you very much for your attention.
Thank you very much, Franco. Really fantastic presentation. I think it fulfilled what I was asking to show how good actually imaging, so not only 3D echo, but also magnetic resonance imaging and computed tomography can really provide details, description of the anatomy, but also of the function of this complex valve. And I think this is very important for the audience that is more interested in the development of course, this valve. But there are also many clinicians that, of course, are very interested in the implication of this information for the clinical. So there are many questions indeed about all the different clinical applications. So I just pick one that recently is quite a hot topic. You dedicate a lot of your presentation about the annulus, and now there is this concept of mitral annulus disjunction that has indeed been associated with ventricular arrhythmias.
Yes.
Do you indeed recognize this phenomenon as a real pathologic one? Some has doubts if it's actually a variation of normal. What's your opinion about it?
Well, this is strange. I just wrote to send a paper about this. Well, all the studies of anatomy from Angelini showed that this junction, so the insertion of a posterior leaflet on the atrial wall instead of the junction between the atrial and ventricular wall, is quite normal. It's present in the normal, also done in mitral valve prolapse. And a recent paper of Daygards, I don't know how is a doctor from, it's difficult for me to pronounce the name, Daygards, something like that, show what?
From Denmark, I think, was it?
Yeah. In Jack, show that even a normal person who have this kind of the mitral annular disjunction, without the prolapse, they have even more arrhythmias than people with mitral valve disjunction and the prolapse. So seems that in some way this disjunction is by itself a generator of arrhythmias. And now there is another paper, a very nice paper from Toe with with a CT scan, which show that even if a few millimeters, 1 or 2 millimeters, this junction is present in 96% of normal. So this is something that we have still study. I just have a more my opinion. I send this paper to JASE. I don't have still the answer, the overview, but there is something because you know, all of the people show this disjunction in systole, no one in diastole. Why not?
That is the tricky part. No, so we still have to learn a lot about it.
Yes,
Indeed.
yes, of course, yes.
And we have a very short for a short answer from a question from Dr. Delgado that is asking how to differentiate a cleft from an indentation. Can you say it shortly?
Yeah. Oh, yeah. Thank you for Delgado. Well, the indentation is a normal aspect of a posterior leaflet, while the cleft is differentiated because for 3 reasons. First is because it arrive until the insertion, until the hinge line, so it's longer than indentation. Second, because it is not in the same position of indentation. So for example, in a P2, it could be a cleft which divides the P2 in 2 parts. And the third, because to be defined as cleft, so pathological aspect has to be a regurgitant. So there will be regurgitation through the cleft.
Great. Now, thank you, Franco, again for all your answers and the nice presentation.
Thank you.
To the next one, which will be given by Mauro Pepi, who is the clinical director of the Centro Cardiologico Monzino in Milan, in Italy. It's for me a real pleasure to have him here because he's been actually my mentor for a lot of research in echocardiography, and he's really a model for all the new generation of echocardiography, and he will be actually the president-elect of the Italian Society of Echocardiography and Cardiovascular Imaging. And Mauro will speak indeed about actually the role of transthoracic 3D echocardiography, because indeed we can have actually beautiful image also with the transthoracic approach. Thank you, Mauro, please.
Thanks, Nina, Franco, dear friends. Do you see my screen?
Yeah.
It's okay. So we recently published this paper. It is a predictive value pre-op 2D and 3D TT in patient undergoing mitral valve repair in the Journal of Cardiovascular Development and Disease. So which is the background and philosophy of this paper? Research devoted 50 years chasing the ideal valve morphology, this dream. And obviously, year by year, we had the historical background with the research activities and particularly rotation TE, Then we have the first real time, which was transthoracic, and not real time, which became a reality only in 2007. So with this background, nowadays we have excellent images in the prolapse, and Franco already showed us excellent images, mainly based on the TE approach. But in 2012, and also Franco was involved in these guidelines, we also say that we had a very important assessment of the mitral valve pathology, and we may include this into routine clinical practice by both 3D, TT, and TE. And the reason is very, very, very clear, because 2D implies mental 3D reconstruction, while the 3D imaging allows an easy interpretation of the images with their true life and phase display of the mitral valve, particularly from the surgical view. The main advantages of 3D TE are certainly morphological abnormalities, quantitative evaluation, training and communication, and monitoring of intervention procedures. We have already seen extraordinary imaging from Franco, and we know that nowadays we have better imaging of the scallops, chordae, cleft, and atolus. And this is a P1 prolapse. This is a flail. This is a P2, large P2 with this large cleft from P2, P3. Which is the accuracy? 2DT approximately has 90% accuracy in the evaluation of the scallops, but with a lower accuracy in complex mitral valve prolapse, while 3D approximately had 94% accuracy even in very complex prolapse, as in this P1 example. And the group from Giovanni Lacanna, Ottavio Alfieri, also showed that we may also evaluate not only the dominant lesion, but also the secondary lesions. And I think that there is no doubt that the TE and the anatomy are very, very, very similar. So we also stated in those guidelines 10 years ago approximately that 3D was also superior to 2D even in direct inspection, which was something that may be strange, but the reason is also easy, because in the surgical inspection we are in a static condition with motionless of the leaflet, where in 3D we have a flail, perhaps a leaflet that are seen in motion. And just an example, this is a very, very important flail of the A2 and P2, and you may see that the early systolic frame shows the flail of the anterior leaflet, while later on in the end systolic frame we have not only the flail anterior, but also the flail of P1. We have already seen from Franco the quantitative analysis of the leaflet and mitral annulus, and these are the changes we see in fibroelastic deficiency to the Barlow disease. So we have already seen the annulus, but in terms of the quantitative analysis, which are the differences? And also Nina were a co-author of this paper. Well, the differences are very, very important. In control 7.1, in Fed 12, and in Barlow disease 15. And this is the reason why we need in all repair to reduce the dimension of the annulus. Just this is a simulation on computer. And you see that when we reduce the annulus, we may also reduce the prolapse. And so there is obviously a very important role of the annulus, as already Dr. Faletra shows us. So moving to the transthoracic. With a few seconds, we may have from the four-chamber view the image, and then we put an arrow and we can see the surgical view very, very easy. And nowadays, from the transthoracic approach, we have very nice images. This is clearly a P2 prolapse and flail in very few seconds. And despite the TE image are obviously more fluent and detailed, the diagnosis in this head-to-head comparison from the transthoracic and TE, the diagnosis is easily done also with the transthoracic approach. In 2006, we first described the head-to-head comparison of all these technologies, 2D versus 94% of accuracy in the evaluation of the scallop with the old rotational acquisition. But what's more surprising that we have 90% with the old technique, which was the 3D TT. Very similar to the 2D TE. This was confirmed later on by several papers. And nowadays, with this new transillumination and photorealistic rendering, we may see very nicely this is a P2 prolapse and other cases. So with this data, we tried to discriminate simple and complex lesion and to facilitate the prediction of a surgical procedure in simple versus complex repair procedure. And the reason of this data is that in simple procedure and complex procedure, despite excellent long-term prognosis, we have a low risk or other risk for residual MR after 3 years in simple procedure, while a higher one in complex procedure. And we clearly predicted the probability with the old technology. And our conclusion was that we may further facilitate the clinical decision in simple lesion versus more complex lesion undergoing more complex procedures. So this is the background of this paper we published recently. And the aim was, does pre-op TT morphology predict repair procedure, simple and complex, but also freedom from MR recurrence. And we studied 1,000 cases, which were selected having optimal quality of 3D and obviously a long follow-up. So we have the final population of 295 cases who had 95% repairability in line with the guidelines. And finally, we have the majority who had at 6 months less than 2.02 minor or trivial or mild mitral regurgitation versus few cases, 29, who had moderate or severe mitral regurgitation. We divided simple surgical techniques with all the different data, particularly the typical quadrangular resection, versus the complex surgical techniques, in particular replacement, transfer of chordate, DNA, papillary muscle reposition, other complex procedures. And the recurrence of mitral regurgitation was clearly different. The pre-op 2D TE morphology, simple or complex, predicts repair procedure that in large majority is associated with freedom from mitral regurgitation. Please note, simple prolapse, simple procedure, and in long run, also 3 years, we have 5% cases who had MR significant. While in complex prolapse, complex procedure, even though the patients are very a minority, that we had 16% of mitral regurgitation. I will not go into details, but just saying that the remodeling of the two groups was clearly different. We have excellent remodeling in the group with optimal results, while in the case with MR more than moderate in the long run, we have a reduction of the volumes LV and LA in the first period of the follow-up. Then they regain volumes in terms of the LV LA, and also the pulmonary artery systolic pressure increase. And I will not go into details on the statistical analysis, but obviously complex MDPI and complex surgery were clearly the most data that may predict the results in terms of the long run. So the conclusion of this paper is that the complexity of mitral valve repair procedure may be predicted by comprehensive 2D TT and 3D, and the pre-op 3D TT morphology identifies patients undergoing simple and complex procedures and predict MR recurrence and favorable cardiac remodeling. So this paper suggested also us to go to a new machine learning prediction models, trying to validate our conclusion. And this study by one of our bioengineer, Marco Penso, first selected a lot of different parameters and variables. I will not go into detail, but the final results was clear. Younger patients, valvular disease, A2 prolapse, and complex surgery were the variables involved in a lower level or a higher risk of MR recurrence. Going to more technical details, we all know that Caravaggio is especially known for the dramatic lighting effects, and a patent is the light were falling at an angle from above, like the spotlight that in turn cast deep. And so we try to have a transillumination, which is a new rendering tool that try to give a 3D depth perception. Just see the apical trabeculae with the conventional rendering and the transillumination. This is a paper from the Roberto Lange group. And with just a touch on the screen, we may move the light both horizontally and vertically to have this shadowing effect of the valve. And with this method, with the transthoracic approach, we have an increase in the localization of chordal rupture and also in left. And these are few examples of this data. Just a case with a severe MR, obviously is a posterior leaflet prolapse, but please note how clear that there is a P1 prolapse that is clearly defined by this new technique. This is much more important with the transesophageal echocardiography. This is a rupture chord. This is an example of the texture. As Franco showed, our dream is also to evaluate the texture of the leaflet. And please note how fragile is this leaflet with these holes. And we, in this case, decided that the mitral clip was contraindicated. This is another case showing this very large P2 with the transillumination and the images from both the surgical view and the LV view. And you may see very nicely this very large cleft between P2 and P3. And as concerned the leaflet and cord attachment, you may also see a sort of anatomy of the attachment of the cord. And Franco showed us very nicely how important are the chordae for the function of the mitral valve. We have several examples. I will go to the chordae. Please note, it may increase this method, which is transillumination, is sort of also glass effect, how easy is to evaluate this small chorda at the level of P2. Another advantage is a new data that is this transparency tool that may merge the Doppler to the anatomy. You see this P2 prolapse with flail, the chordae, and this image of the leaflet, the piece effects of the leaflet. And also how easy it is to evaluate this perforation of the valve with this new rendering. Finally, as concerns the prosthesis, and we wrote this paper with a lot of 3D data, but why this is so important? This is quite obvious with also the 2D TE and color. This is obviously a paravalvular leak. But with the 3D, you may observe that is not one leak, there are two leaks with obviously clinical implication if we go to a procedure percutaneous closure of this data. I will not go into percutaneous procedure, but please note a mitral clip, and this is a percutaneous closure with the device. And what is extremely important in the mitral clip that we may have more images, more effective images with the shadowing of the catheter, the grasping of the leaflet, and also the final results. And as concerned the residual jets, we may merge the presence of the clips as well as the very trivial regurgitant jets in this case. I also quote this paper from Franco, which is the fusion of the images of the echo, 3D echo, and diffusion imaging. That, as concerned 3D TE in this review, it is quite obvious that we have a lot of new indication and advancement in comparison with the standard 3D TE, and very close to the 3D TE in the majority. And finally, 3D TE is not only the morphology, but also the tricuspid valve, right ventricle, left atrium. We may have, in all these cases, not only the mitral valve, but also the tricuspid valve, which is not easily evaluated by the standard 2D. We may evaluate the right ventricle with this is another paper with Nina 10 years ago. And nowadays we have with the artificial intelligence, the deep learning, also in few seconds, the left ventricle, left atrial volumes and function. So this is my last slide. So 3D TT reduce analysis time and makes quantitative assessment more objective and reproducible. This is a case of a young man where the P2 prolapse, left ventricle, left atrium, right ventricle, and tricuspid valve in approximately 30 minutes. So I thank you a lot for your attention.
Thank you very much, Mauro. Really, really nice presentation. I think our audience now is extremely enthusiastic about hopefully echo and imaging, and also about all the new advanced tools that you showed us. Which I think indeed will help implementing more and more the use of 3D transthoracic in the clinical practice, because I think your center was a bit a pioneer in that, but some centers kind of have difficulties in implementing really in the in the clinical practice. Do you think this advanced will really help other centers to indeed implement it really in their routine? Or do you think is really just a learning curve and operator dependence that remains a little bit?
This is an important point. I think it is not at all complex to do these things. It's just, you know, you have to try for the mitral valve nowadays. After having an acquisition of the 4-chamber with the different companies, you may very easily go with an arrow and see the surgical view. Obviously, 3D always depend on the 2D quality. This is quite obvious. But nowadays, the majority has excellent images. What I think is more important is not only to think that 3D is only TE. Obviously, TE for the procedure, for the surgical approach is much important, is very, very largely applied. But the 3D transthoracic had a lot of opportunity. And also the quantitative analysis of the chambers is extremely important. We have to move to the 3D concept is not complex. For the tricuspid valve, no doubt that is the gold standard.
Yeah, I agree completely. No, indeed. And from the audience, we have a question specifically about the translumination tool. Asking indeed if this tool is available offline or is something that you can use only indeed live when you're scanning, and in which indeed patients do you think is particularly important, where it really enhances the normal 3D views, or is something that we should always use?
The touch screen allows you to do that in a real time. So just, you have just to touch the screen, and you can move the light around the valve or around the structure. So very easy by both the transthoracic of the approach. First, you can go live. Obviously, if you have already acquired the images, you can obviously have a retrieve of the images and go back and do that also in offline. So it's easy, is very, very friendly, and I think is maybe utilized in the majority of cases because the shadowing is giving you the true 3D image of the structures.
And in which patients, therefore, you use it the most?
Certainly, from the transthoracic approach in the mitral and tricuspid valve in mass, every kind of mass, because during a very, very quick movie of a mass, the shadowing effect is very important, and the structure is more detailed. In terms of the DT, we use it in all cases.
Great. And Franco, I think had a question also. You raised his
Yeah,
hand.
can you hear me?
Yes.
Yeah. Just to say, Mauro, I agree with you because of this new light movement of it could be important. But sometimes I spend half an hour to just decide which of the position is the best to understand. And so this is a time consuming. And as far as I know, in not so many cases, they just improve the main diagnosis made already with the, I just, for example, during the procedure, I just put any times normal volume rendering and this new volume rendering side by side. And well, I will say that, and I show to my fellow, but they say that sometimes they better understand without this new illumination because probably we are used to look at this, but this is just my impression.
No, Franco, obviously everyone has his own experience. I think that it is true that you have not in all cases dramatic increase, not at all. But just another point, if we go only to the surgical perspective, sometimes this effect is not so important. But if we go to a more longitudinal or in other views, the shadowing is much more important.
Yeah.
So it depends also on the structure. We're just another example. We're working a lot on tumors now for several reasons in our institute. And in these cases, the perspective of the image is very, very important. But it is true, we can't say. And another point, in cases with the low level of the images, maybe sometimes may increase the image. If you have an excellent image with the standard conventional, probably you have not this dramatic increase.
I found Yeah, just 1 minute. I found that, for example, to define the size of the phosphovalis, for example, for the puncture, while putting the light behind the phosphovalis, just define very well the phosphovalis. This is something that is useful,
Sure.
really.
No, indeed, in some specific cases, really helping.
Yes.
So I would like to thank you both. I think it was a great webinar. I think the audience was very happy, and I hope also they will share with the colleagues for indeed the recorded version afterwards. And yeah, I wish all of you a nice day and for the next appointment. Thank you very much.
Thanks,
Bye-bye.
Nina.
Bye
Ciao,
bye. Thank
Bye,
you,
Charlotte.
everyone.
Bye-bye, Charlotte.
Bye,
Bye.
Charlotte. Thank you very much.